Moving on, we are talking about palliative medicine today. Why is this important? It's important because we see it every day in our clinical practice. And it's part of, clinical medicine is where we are involved in the cycle of life from birth to death. That's our role as GPs. So palliative medicine is a very important topic for us as doctors. And in this session today, we will talk about how this palliative medicine links to the exam, how we see it in clinical practice, and of course, the tips and strategies for you to excel in your exam. And we have a role play session afterwards. Okay, so just a kind reminder to everyone that this is a masterclass. We are not nitpicking or going back to the very basics of the exam. What we are doing is combining the most important points, so a summary of the last 3 years of our learning around palliative care or palliative medicine in primary care, so that we are having a refresher at the same time, learning the things that we need to pass the exam. So every one of us here should be in ST3, likely in ST3. So the tutorial is suited more to ST3 doctors because each of us would have had an experience of palliative care in our clinical practice. You must have had a patient. You would have gone on home visit and have a case of end-of-life care. You would have spoken to a district nurse about palliative medicine. So palliative medicine or care is not new to us. What we are doing today is combining all we have learned, all our wealth of experience in a brief masterclass, and then talking about the points that gets us over the finish line to get green pass or clear pass in our exam. So now remember that chart structure. Please again go into your chart. And now that you just take a look at the blueprint, SCA blueprint. This is a brief exercise for all of us. When you think about palliative care, which of these blueprints do you think palliative care would relate to? Use the numbers 1 to 12 and just put in the charts. You can put as many numbers, 1, 5, 6, 9, as much as you can. Just think about it because it gets us to think outside the box to say, oh, palliative care, if it comes in exam, how can I expect it? Or in what clinical kind of scenario would it come about? And this helps us think. So great answers. Some people say, I've seen 2 4s, older elderly people with elderly care. Good. I've seen some 3s and 3s, long-term care, including cancer. Very good. So those are the 2 most common ones. Right, so I'm seeing more 11 and 12, which is really great because we can actually have a professional conversation with a district nurse in our clinical practice, talking about a patient who is dying. So there's other people within 6, and what other ones do we see? Interesting. So we are having more of the 3s and 4s, 7, 11s, and 12. 3 and 4 is more common. So no one said 5. Mental health. I've had a patient in clinical practice where it was the relative that came to say, oh, I'm really struggling and my spouse is going to die. I've had another case where it's a lady, but it's her mom who had dementia, and I had to go on a home visit. And even after the mom died, I have to also offer bereavement services to the daughter and support to the daughter. So that's palliative care presenting as mental health. Now, I'm looking at number 6. Oh, someone said number 6. Thank you for that, Ian. Urgent and scheduled care. You've had a case where you've seen a patient in hospital, but you think, oh, this patient might be cancer. I'm going to have to do an urgent referral to the hospital. So this exercise quickly makes us think about the different ways that we can see palliative care in clinical practice. And the SCA exam is a reflection of our clinical practice. So I love Dr. Chogo's answer. She says it pertains to all. And that's my answer as well. You can see palliative medicine in all of them. But this is what I wrote. This was mine. The most common one I have seen in clinical practice. I may have seen breast. I've seen a lady with breast radiotherapy, but it was more of pain control. She wasn't end of life. She was still in the curative phase of her illness. So I've seen one. So it can happen in everything. But these are the most common ones that I have seen in clinical practice. So no one said 8, ethics. And palliative medicine ethics in palliative medicine is very important because when you are discussing future care documents, lasting power of attorney, or checking mental capacity of the patient to tell you their preferences, you are also dealing with those aspects of ethics. When you are dispensing medication and you want to make sure that what you've given is fair and just equity to the patient, is all part of ethics. So this just shows you how palliative medicine is very important to us in our clinical practice. And by proxy, if you find it in exams, that's just the same way. It's a very common situation, a scenario that we can have in clinical practice every day. So let's just recap what palliative care in clinical practice means. We know that palliative medicine, the goal of it is to manage pain and symptoms for the patient or care of the dying. And as much as we can, we want to ease their suffering, give them the highest quality of life as much as we can, as well as respect their preferences. So respect and autonomy. So that's where the ethics comes in. It's also important for us to have the right communication skills for these patients, or even when we're talking to this patient, or even when speaking to other healthcare professionals. It's important for us to also remember that palliative care is a multidisciplinary approach. So holistic care is very important in managing palliative medicine. And We also remember that sometimes palliative medicine can come in any phase of the patient's illness, and it can occur in any disease. So that's why it pertains to all. And it can come, we can also have discussions about palliative care as when the patients are still having illness. So I've had a case where a patient comes in and says, oh, I've just had a diagnosis of MND, and I'm still struggling with the conversation I have with the consultant. What's MND? What's this drug? Is it curing? So patient is still having treatment, but the patient understands that MND is not curable and is going to be progressive, and is going to end up having a shorter lifespan than expected. So while the patient is still having treatment, you may still have that conversation of palliative care. So you can see that palliative care is not a standalone discipline. It's rather woven into every discipline and every part of the SCA blueprint. So I want us to think that way when we are preparing for our exams. So if you think about how palliative care was in the past, a patient gets diagnosed. This is an old model of care. Patient gets diagnosed, the doctor treats the patient, and if the patient gets better, gets the thumbs up, yes, off you go. And if the patient doesn't, they end up in the hospice, they pass away, and that's the end of patient care. Now, this is the old model of care. And as you can see, the doctor's care as GPs ended when the patient passed away. We didn't have bereavement support, or even if the patient got better, there was no support to help them manage the psychological impact of having that condition, for example, cancer. But palliative care has evolved, and this is the model we are currently working with. So there is a thin line between treatment and moving a patient up to palliative care or end of life. So while the patient may still be having treatment, you may still have that conversation. And it gets to a point where you're treating the patient, and if it doesn't work, then the patient moves into that full hospice end of life care, and then the patient passes away, unfortunately. Now, even after the patient passes away, we still have to see that bereavement services continues. So that's gone off. So here's supposed to be bereavement services in the blue box. It continues even after the patient has passed away. I gave a case just now where I had a patient in clinical practice. It was the daughter, mother had dementia, mom passed away. I had all the forms, documentation, cremation, all done. And then weeks later, I was still talking to the daughter because she was struggling. But it all started from first contact here all the way. And that bereavement services could go up to weeks, months, or years. Because after the patient passed away, the relatives have to deal with a lot of stress. I've had a case one time, which was very troubling, of a patient who passed away, and I signed all the documents. Patient went to be buried. And then the doctor contacted me after a while saying her parents had been buried in the wrong spot. And you can imagine that my shock as a GP and her shock as my patient. And the patient in the ground who has passed away, not having a shock. But you can imagine that even though this patient has passed away, my care as a GP still continued. So it just gives you an idea that palliative care, palliative medicine goes beyond patient's death. And if we think about this, it helps us also get into that mindset and that frame to understand what we need to be doing in clinical practice, and by proxy, the exam as well. And remember that throughout the phase of this patient's condition, the care is connected. So you have letters from the oncologist, you may have referred to Macmillan nurses, you may be prescribing medication. It's not a boxed kind of treatment like the old model, but rather care is connected, and it's a holistic multidisciplinary approach. So for us as ST3s or GP, so for you as ST3s who are in your final phase of your training and you're preparing to be an independent doctor, what kind of resources do you have available to help you manage patients effectively, or to improve your knowledge in palliative care, or to get that extra help if you need it, if you have a patient you're struggling with? So this is for you, the GP, as an expert, because we are all training to become experts in the field of primary care. There is a nice CKS, we all know that there is a page there on palliative care that breaks things down into new diagnosis, terminal phase, and end of life care and bereavement services. So please have a look at the nice CKS, because this exam, we may all have different things we do in our local practice, but the nice CKS is central and meant to guide us in our practice. Now, there is a document called the National Framework for Local Action. I'll talk about that shortly, which kind of sets out what local communities or local GPs can be doing in their local practice, how they can adopt the whole principle of palliative care in their local practice, so your PCN. And of course, even within a PCN, you'll find that your GP practice is different from what's done next door. For example, I've worked in a GP practice where every month we have a meeting on palliative care, and we bring up all the patients who are on palliative register, and we go through each of them, and then we reassign the GSF codes, blue, red, green, amber. If this patient is very unwell, the entire team is aware of it, so that if we get a call, this patient is end of life, we already have that information. Then I moved to another practice where one doctor was in charge of everything. So every new case of cancer diagnosis or any case that comes in, she reviews that. She reviews the annual cancer care review annually, and she does the GSF coding. So this exam is not black and white. We're not expected that everybody should come say exactly the same thing. What is expected is that you are able to say what you do locally or in your practice that is safe, efficient, and patient-centered. So it's important that you are taking these first three resources into consideration when you are writing down your own case note, how you manage palliative care. And of course, cancer care review. I will share the link to cancer care review. It's a great link. I was in a practice where I was working part-time, and I was working independently for a long time before I CCT'd. So they were sending me a lot of reviews to do on my own. And when I got a cancer care review, I was like, I've never done this. And the practice manager sent me a link, and I loved it. And that's the link I'm going to share with you all, because in there, the link has what to expect, the kind of conversations you should be having with patients, the QOF and everything, because part of being expert GP is that though you've managed the clinical aspect of this case, so you meet a patient and the clinical aspect has been sorted, there are also other things you do in practice management. For example, put the patient on palliative register, assign the GSF, get the diagnosis, things that you need to be doing to make sure that your care is holistic. So this is why I felt cancer care review is an important thing that we need to talk about and that you need to know as well, because you are going to be independent GPs in the near future. And of course, we all know the yellow book for palliative care that gives you the breakdown of anticipatory meds, how to change meds, compatibility. It's important that we know how to manage intestinal obstruction in palliative medicine, end-of-life stages, or even opioid conversion when you want to change medication. These are all principles of palliative care in the yellow book. And there'll be links available for you in case there's anyone who's you're in a different locality, but you don't know what I'm talking about, but these things are all in there. Now, the GSF framework is something that is, it's a document that helps us identify when a patient is declining. And I'll talk about that shortly. So it's very important that we know the GSF framework, because when we are meeting a patient in clinic, or we, for example, have a role play, there are identifiers in that framework that we need to be putting our ears down for, so that you can easily recognize, is this patient dying? So we'll talk about that shortly. And of course, we all know the future care documents, like do not resuscitate, advance directive to refuse treatment, all the documents. It's also important for us as doctors that when you're caring for a patient, think about the charities and the foundations out there that can give you that extra support for the patient. For example, MND. MND has an association, and I've had a patient say, oh, I've got a diagnosis and I've contacted MND Association and I have an appointment with them to talk about what my diagnosis is. And I was very happy, and I didn't know that association existed until I heard that patient say that. So think about the charities around. Dementia, there is Dementia UK. There is which other one? COPD UK, or any other conditions. Heart failure, there is BHF, where patients can go and read resources to understand their diagnosis or what to expect. And there are so many things out there. For example, in my local area where I was in a cafe one day, and I stood up and I saw this board. On the board, they had this dementia cafe. Come in on a cup of coffee with Costa and just talk about your dementia diagnosis, or if you're struggling. So we need to know what is available locally, so that we are also signposting patients to that as well. So these are the resources. I'm sure there are more out there. So look at your practice, look at what you have, make a list of the common things that you use as a resource to understand or to signpost patients to if they need that extra help. Okay, so I've got a comment here saying CCR is meant to be done every 6 months, and that's true. If the link I sent, it will talk to you about when CCR is meant to be done. So once a patient gets diagnosed, they are meant to have their first cancer care review within 6 months of that diagnosis, and then every 6 months afterwards. And the cancer care review is meant to help us identify areas of need for the patient, so that we can be supporting them early. It doesn't have to always wait until the patient is dying or in palliative care. So this is why CCR is important. Okay. So this part is about talking about the local action, the framework for local action, which I mentioned. And there's a link there so that if you want to go look in that booklet, you can always have that look. PowerPoint will be shared later on. Well, I wanted to bring these rainbow colors here so that we can have a look at this, because if you are consulting, or if you're having a role play with the exam and your consultation has not reflected these nice rainbow colors, then I think globally, you haven't really completed your task as a GP. So this framework says that each person should be seen as an individual. So that's respect and autonomy, receives fair access to care, equity, ethics, maximize comfort and well-being. So patients' preferred place of death. These are the kind of questions we need to be asking. Is the care that you have offered, is it coordinated? because we as GPs, we need to take ownership of the care that we give to patients. All staff should be prepared to provide care. So you need to also understand that as GPs, you are bringing in other teams that could also help in managing these patients' care. Speaking of other teams, quickly in the chat, I mentioned that this is going to be a bit interactive. I want to get you to think about the other teams that you can involve in patient care. There's a nice list in nice CKS, but right here, let's learn together. In the chat, quickly put the other teams that you can involve in patient care. I'll go first because I know everybody will always say this. Social prescriber link worker. I've taken that out because everybody mentions it like stock phrases now. So lovely. So Vivian said Macmillan. That's great. Any other one? When I think of Macmillan, I think of the sister of Macmillan. Anybody else? So we have 69 people here. District nurses, great. SALT, very good. Speech and language therapy. Some people don't always think about that. Aspiration pneumonia is one of the early identifiers for somebody with dementia. So that if the patient keeps getting aspiration pneumonia, you need to get SALT involved. So you have to think about these things. District nurse, Admiral nursing team. Okay, I don't know Admiral, Dr. Dev, so that may be something local to you, but that's a learning point for me. I'll just write it down, Admiral, and I will just have a read about them. Physiotherapist, that's great. Who else? Occupational therapist, dietitian, nutritionist, it has a dietitian. So you see, it's not just us. Somebody hasn't said the main big one. UCR team. UCR is new for me. That may be a local one, but I'll have a look. Social services, brilliant. If there is a safeguarding concern, do you need to be involved in social services? So, or making that referral? That's good. Marie Curie has been there, so we got there. That's great. How about the oncologist or the specialist involved in this patient care? Because we'll talk about the patient's journey towards death very soon. Depending on the phase of the patient's illness, we might need to be going back to the specialist to say, I need your advice, or I need to see this patient. What about the palliative team? Because they might be different from the oncologist, or they might be working together, but they might be different from the MND team, or they might be different from the breast cancer team. So palliative team, when we have difficult palliative cases that we're trying to control pain, we need to get that extra help. That's the palliative team. It is expected that for us as doctors, as GPs, we should know the very basics of managing palliative care. We should be expert at it. But there might come a time when the case becomes really difficult. We are now involving the palliative team. So we take ownership of that case. Don't always rush to quickly refer the patient off to oncology and palliative team. You need to show that you have taken ownership of that case, because you as a GP, you are the expert, you are an advocate for the patient, and part of your role is that you are also coordinating care. So when I saw this rainbow call, I thought, oh, this is very important, because the global tax for us, if we are doing this case, if your global tax in managing a palliative care hasn't really reflected these nice rainbow colors, then you may be seen as inadequate for that station. So it's a very important one for us to just look at this and say, okay, I need to be hitting these points when I'm doing my role play or managing my palliative cases in clinical practice. So about the GSF framework, it's a document, it's a framework that guides us to identify patients early. And depending on the patient's stage of their condition, phase of their illness, the questions would vary. So the first question goes, ask yourself the surprise question. Would you be surprised if this patient were to die in the next year, months, weeks, or days? So if you're having a role play in your group and the person is saying, oh, doctor, this patient has this, the palliative care team has discharged, patient has deteriorated, he's not eating, he's not getting out of bed. Would you be surprised if this patient died in the next few weeks or days? That's the number one question. So this is why I want you to think, how does this particular slide relates to my exams? Because when you are looking at that doctor's notes and you're looking at what's there, are you identifying that this patient might be approaching end of life? Now, if you are not sure, or if it's not clear, like in clinical practice, where patient comes and they may be anxious and stressed, and we may be given limited information before we go on our home visit, the step 2 is about general indicators of decline and increasing need, and it's specific to the condition or to the organ. So if you look in the document in the link, you would see the points on how to identify early decline for heart failure or cancer or dementia. For example, COPD, this was a very common AKT question, and I will struggle with it with GP self-test back then. The AKT question would say, which of these is easy to identify? So for COPD, I think it's distance, not walking distance of 100 meters, 3 admissions, more than 3 admissions, ITU, symptoms of heart failure, cor pulmonale. So those are the early general indicators of decline for COPD. So for me, when I was studying on this case, because I really struggle with palliative medicine or palliative station, preparing for my exam, I would look at the doctor's note and say, oh, this patient has had 3 admissions this year. Even if the patient is well, I need to be testing that information to find out whether this patient has conversations around DNA CPR or palliative care or preventive, future documents, what they would prefer. Or if the patient is on home oxygen, I've had a case where I went on, they said patient has just been discharged. I would go see the patient for a home visit. And I was struggling, what's this home visit for? But when I got there, I realized this patient was on oxygen. And I spoke to the patient, you're on oxygen, you've just come out ITU. And I tried to initiate the conversation around DNA CPR. And this gentleman would not have it. But you see, I was able to identify that there were early decline in the patient's, where am I? There were early decline indicators for this patient who had COPD and was now on home oxygen. But this gentleman was not willing to have that discussion on DNA CPR. And unfortunately, he died a few weeks later because the indicators were there, though he was not ready. But you see, just by going in and seeing the gentleman and having that conversation, using the information I had, I was able to at least initiate that conversation and document that these were his preferences for that point in time. So this is important because if you are looking in your doctor's notes and you are seeing some signs that there were indicators for early decline, it's there for a reason. Think around it and see how you can use that. So for example, you might be discussing with a healthcare professional who then says, oh, he's just come out of hospital, he doesn't want to go back, he's on oxygen, he's not eating and drinking. Those are indicators there. So these are the ways that I use this information because I'm not just coming here to say, oh, this is how to manage a COPD palliative care end-of-life case. I'm providing information so that whichever case you are given, you are understanding the foundation and you are able to manage that case, no matter how the case changes, no matter the clinical situation. And also, we're still recapping palliative care in clinical practice, what we do in primary care. So we remember the principle of breaking bad news. It's very important. And there are some phrases that we need to be using well because it's all part of IPS. So spikes, everybody remember this mnemonic from AKT or even ST1s. It's very common. Now, I know the exam is virtual, so you may not need to be setting the room and inviting them in, but there are certain things when you are having that role play, there are certain questions that you need to be asking to elicit that you are using this method in your exam. So you might ask the patient. So a patient might come to you and say, oh, doctor, excuse me. Patient might come to you and say, oh, doctor, I've had a diagnosis of MND. The doctor, the specialist said I should come talk to you about one next to do about my new diagnosis. Part of your data gathering is to test the patient's perception. So what do you understand about your diagnosis? And let the patient give you that information. So it's an open-ended, open question for you to use in your data gathering. Now, you may have some case where the patient may come and say, oh, doctor, I'm scared, I don't want to know. You've got to be asking them, is there any information you would want me to share? So for example, this MND, is there anything else you want me to talk about with your diagnosis? Is there any question that has come to your mind? So you see, you invite them to present information so that you are using all of this in your management. And of course, when you've done your data gathering and you're breaking that information to the patient, you are providing that information without medical jargon, you're pacing yourself, giving patient time, and you're providing that knowledge in a concise way that patient can assimilate, because breaking bad news is never easy for us as doctors or for the patient. And there are verbal and non-verbal cues and communications phrases that we can use to make our consultation better when breaking bad news. And I'll come to them shortly. And of course, our clinical management, we'll come to how to manage this, but this is a summary, because it's a masterclass, a summary of everything in palliative care over the last 2 years, so that when we go to that data gathering or the IPS, you understand the foundations of all of this. So let's go, bear with me. So now let's talk about how to manage a case of palliative care if you are with a patient. So this exam, we are graded on IPS, data gathering, and clinical management, but also our global skills as doctor is very important. That overall presentation that you present, the overall look you present to the examiner or to a patient who then feels, oh, I'm confident that this doctor knows what he or she is doing. That's the global tax for our exams. So for example, a patient, in palliative care, you might have to see the patient, you might be talking to the patient directly, or you might be talking to third party. That's important. So these are the different ways you can present in clinical practice and by proxy the exam. We've got to demonstrate holistic care in whatever we do. So the biopsychosocial model of palliative care is very important in your data gathering, because without using that model, you will miss very key parts in your data gathering. We've got to establish the patient's journey in palliative care. So once again, so that we don't have death by PowerPoint, in the chart, quickly, think about the different ways patients can present. I will start with one. A patient can present, a palliative case can present as new diagnosis, where I'm seeing the patient for the first time with new symptoms, and I'm making that urgent referral to hospital. What other way can patient present in palliative care? So for example, let's say prostate cancer. What other ways can patient present in palliative care? I'm looking out in the chat. So that chat function is there. Pain control. So patients can present in the middle of their condition with symptoms. They're not new diagnoses, they're not end of life, but you need to manage that care right there. So pain control. Worsening symptoms, pain control, complications. So complications with nausea, UTI. Okay, good. So these are the clinical situations that patients can present. Okay, perhaps I need to rephrase my question. So I need to go back to my table and rephrase that question. So what I was hoping to see is, one, patient can present as a new diagnosis. Patient can present as an established diagnosis. It's new, but the patient is very anxious and very stressed and wanting more information on their condition. So information request. In clinical practice, I've had a patient come in, the patient is neither ill, neither palliative, the patient is currently having treatment. I've had that case in, that was a cancer care review in between the beginning or the end of the journey. So we're talking about patient journey now. So if the patient gets that diagnosis, every possible phases the patient can be before they get to end of life. So I've had the patient in the middle where it's not new, they are coping well, no symptoms, they're just having their cancer care review, or they might be presenting with a symptom. So the biopsychosocial model is very important. Or the patient can present as palliative, where they are not end of life, but they are no longer in the curative. So they've been discharged by oncology team saying, unfortunately, there's not much we can do. We've discharged the patient back to your care. The patient is aware, but the patient is not yet end of life. And the final one is the patient is now end of life. So that's the patient's journey in palliative care. Now, if we understand that patient's journey, when we see a case, and you are able to establish that patient's journey, your clinical management will adapt to the phase that patient is in. For example, if I see a patient who is a new diagnosis and is going to get chemo and all the curative treatment, having an end-of-life conversation is not appropriate for that patient. Do you see what I mean? So if we establish that patient's journey in our data gathering, it helps us to set out the goals that we need in our clinical management for that case. So part of the, so thank you everyone for doing that task. So at least it gets us to think about the different ways. Someone said failure to cope from family and patients. Brilliant. I missed that one out because, like we said, the mental health stress of a new diagnosis or the condition doesn't just affect the patient, it also affects the family. So you may have a third-party conversation with a relative saying, oh, I'm really struggling with caring for my relative who is in palliative, under palliative care. That's another way of the patient's journey, even though you're not talking to the patient directly. So we've mentioned this already, part of your global task in this exam is that you are breaking bad news effectively and appropriately, and you're giving diagnosis without medical jargon, and that we should be able to explain complex information. Now, conversations in palliative medicine or palliative care is difficult, and complex emotions can come into play because the patient is stressed or anxious, the relative as well, and then you, the doctor, can also be triggered. Unfortunately, but we are humans, and some of us may have had life experience, and having that conversation may trigger our own experience. So it's important that we are also able to manage ourselves because it's triggered us, and focus our consultation on the patient. So that's why complex emotions can come into play in palliative care. We need to be comfortable with talking about death and dying. And patients might throw in difficult conversation about prognosis, about the medications. We need to be on our feet because if you've handled that case well and you've gone to the end and the patient says, oh, doctor, can you please explain these medications for me again? I'm worried that I will be in pain. How do you go about explaining anticipatory medications to the patient effectively without using medical jargons? And these are all the global tasks that will come into place. Now, some patients may have comorbidities, for example, epilepsy, diabetes. How do we manage those medications when we are putting patients in end of life? We know this already because in 3 years of being GPs, we know that, or GP trainings, we know that when we are putting patients on end of life, we are going to take off non-essential medications and talk to the family and the relative about the medications that need to be in place in case the patient needs them. So epilepsy medication, if you're canceling that out, what medication are you putting in place to make sure that if this patient has seizures, it can be stopped or controlled? And of course, ethical dilemmas always come up in palliative cases. So you might be taking data gathering and then you may establish that, oh, the person you're speaking to is not the person with the lasting power of attorney or next of kin, but the person wants you to list them in the records as the next of kin. And I've had that situation in real life, and I had to remove myself from the family conflict and just maintain that professionalism. So you might have those kind of ethical dilemmas that comes up in real life or in your practice. But if you don't ask the right questions or know the right documents that need to be in place, you might be doing the wrong thing for the patient. And of course, like our colleague said, the mental health and managing the stress and anxiety. So these are some of the global tasks that needs to be coming up when we are managing a palliative case. So data gathering. Let's just put our mind into that role play situation. Hi, my name is Dr. E. Who am I speaking to today? Oh, doctor, my name is this. Am I speaking to the patient? Am I speaking to a third party? If you're speaking to a third party, it would be nice to ask, okay, where is the patient at the moment? Are they aware of this call? If they are, do you have permission to speak on behalf of this patient? Because this is where you are showing that global tax that you are able to manage a third-party conversation. Confidentiality is important. There is a case in SCA revision that I role played in where the patient comes and says, oh, I want to talk about my mom's diagnosis. My mom won't tell me anything, so I'm calling to talk to you about my mom's diagnosis. So that's a third-party conversation. But if you don't ask those questions to establish and check confidentiality, you've made a big red flag right there in that clinical management. And so, of course, we give the patient that open statement, their golden minutes to say what's most pressing on their mind. So my friend would say opening gambit. And I learned that patients can present with any of these three biopsychosocial complaints. Now, the biological symptoms of the cancer or the complication can be what made the patient come to see you in clinic that day. It can be mood or anxiety or something relating to their welfare. It can be the social impact. I'm not coping at home, or I'm taking carer's burden. I'm taking care of my relative and I'm stressed. Or I've been taking care of my relative, but we're really struggling for money and I need help. And of course, part of the social things questions you need to be asking is about the future care document. So if you are doing data gathering for palliative cases, your data gathering needs to cover these three aspects. Because if you do your cancer care review, if you go back to your practice this week and you say, okay, I'm going to look into the ADENS template for cancer care review, you would see that the cancer care review in your ADENS template actually covers these three, biopsychosocial. And you've got to be asking questions relating to the three of them for your patient. If you don't cover the three of them, then you've missed a big hole in patient care, and you will not be able to implement that holistic patient care that we want to see as part of your global tax. And depending on the clinical case, you've got to think about your differentials. Is this complaint something new, or is it an extension of the condition? Patients may come and complain and say, oh, since I've had breast cancer, anytime I come and see the doctor, that's all they focus on. That's because sometimes as professionals, we see that this as a label and we don't want to look past that. But it's important that we are also testing our differentials. Could this be something else? So you may have a case, palliative care, patient is deteriorated. And when you ask questions, could this be UTI that's making this patient now hypodelirium and he's not eating anymore? So don't just assume that everything is the irreversible disease of cancer or end of life. You've got to test your diagnosis or test your differentials to find out. Once he complained about any tummy pain or any other symptoms like any blood in his urine, ask your questions to rule out your differentials. And your red flag will depend on the clinical situation. So if it's a social case and you're picking up a lot of safeguarding issues, you've got to ask and say, who is caring for the patient? Have they been left alone? For example, if it's a dementia patient who is in end of life, part of your red flag needs to test the patient's safety. Are they cooking? Are they wandering off into the streets? Because you've got to make sure that patient safety is important. It's part of your red flag. So it depends on the clinical situation that's in front of you. And we've got to be asking for mental capacity for the patient. If you're speaking to a healthcare professional or to a spouse, say, is he still able to tell us what he would prefer? Because if you're going to have that conversation with a relative, you've got to know whether this patient can tell you what their preference for care is. So you've got to ask about mental capacity. At this stage, I think we all know ICE and PCO, so I won't drum on that so much. And we know why it's important to be asking that in all our stations. And because whatever case is in palliative care is an established diagnosis, apologies for that, I would recommend also asking about these CFAM questions, which is a mnemonic. So you've got to weave all of this into your data gathering, and this is why you practice and role play to build a consultation style that's unique for you. So a patient might come and say, oh, I've got you may be speaking to a spouse now or a healthcare worker and says, oh, he has a diagnosis of prostate cancer. It was diagnosed 5 years ago, but something is wrong. I just don't know what's going on. So you've got to ask, how has this been treated in the past? Have there been any problems? Is he still on any medication? Is he still with the oncologist? Is he still being seen by the Macmillan nurses? So that's follow-up and support. So you see, I've asked one question, is he being seen by the oncologist or the Macmillan nurses? That's me asking a question on who is available to take care of this patient, as well as if this patient is still having follow-up. So you tailor your questions and your conversations to what's going on in front of you. And then an action plan. Did they talk to you about what to do if this happens? Oh, yes, we've got a care plan here that says, EHCP, that says if this happens, we should call the GP. And of course, in every long-term case, we should be asking for mood for the patient. And sometimes you ask for impact for if you're speaking to a relative to see how they're coping. So impact and mood goes hand in hand, and weave all of this into your conversation. And depending on the patient's care, it's good to also ask, depending on the patient's journey, you might also want to ask if this patient already had anticipatory medicine in place, have they used them if this has been prescribed? And if you're having a conversation about patient's preference, what's their preferred care? So we'll talk about phrases that can help. Do they prefer, the patient may say, oh, I'm worried about having pain and I want the quality of life to be as optimum as possible. So patient is opting for quality rather than prolongation of life, or their hopes and fears for the future. Because if you don't ask these questions, your goal for your clinical management will be lacking because you have not really done anything that's patient-centered. And also remember that in our data gathering that care is multidisciplinary, so who else is involved? Who else have they contacted? What do the relatives know so far? Because they might say, oh, I've got the number for Macmillan nurses and they said they're going to come tomorrow. So use the doctor's note, whatever is available, but always, these are some of the good questions to ask as part of your data gathering. So these are the documents that we ask in palliative care or end-of-life documents. So what I tend to do is I tend to ask the first 3 or 4, and then I may say, there are some other documents that we need to talk about. Is it all right if I talk to you about them when I come out and see you? Because if you were going to ask each of these documents one by one, you might lose a lot of time. So something I've done was, this might be a difficult conversation, and you may already have this conversation with the oncologist. Did anybody talk to you about a resuscitation form? So you see, I've signposted and acknowledged that it's difficult to talk about these things. I've signposted that I'm going to ask a question that might shock them, and then also acknowledging that this might have also been discussed. It's not just going, do you have DNAR? Do you have lasting power of attorney? Who has the lasting power of attorney? So conversations in palliative medicine is difficult, and we've got to learn those phrases that will help us build rapport and increase our IPS for this exam. So speaking of IPS, here are some verbal phrases that we can use. This doctor who wrote this book, very nice mnemonic called Nurse, has used it to frame some of the ways that we can have conversations with patients. So name it, name what you see. So it might be a video consultation and patient is upset. You seem upset. I can see that you are upset. If it's a telephone, you can see you sound upset. In the group today, we've posted a PDF of other phrases that you can use. Look into them. We don't want you to just copy and paste stock phrases. Weave this into your conversation and find your own style. So ways that you can demonstrate understanding. So you can say something like, this must be hard for you to talk about. So that may be a relative who is crying and upset, and you are sure understanding that it's a difficult conversation. So you might say, oh, it must be difficult taking care of your spouse. I can see that you've done a lot to support them. So you're building that IPS and that rapport. So you're showing understanding that it's a difficult conversation or a difficult situation that the patient or the relative is in. Respect what has been done. So you may have relatives who are taking care of their family member, and the burden of care is hard. So to show respect for that, you can say something like, I'm so impressed that you have been taking care of your mother by yourself all this time. It's very kind of you. How have you been coping with all of this? Or how have you been coping with work? So you say, I've shown that respect for the hard work this patient relative have done. I've moved on to my next question of asking how they've managed caring for their relatives and work and any maybe kids or whatever they're doing. So supporting, this helps the patient feel less abandoned so they don't feel isolated. So you say something like, our team is here to help. There are a lot of things that we can do for you. Our team is here to support you. So you are building our IPS, nice phrases that you can use. And the E is for exploring, ways that you can explore when the patient comes in with a golden minute. You mentioned that your mom, so that case where the patient comes in essay revision and the patient says, my mom doesn't want to tell me about her diagnosis. You can then say, can you tell me about why your mom wouldn't talk to you about this? Or how have you managed to take your mom to hospital without talking about this? So explore, because when you explore with nice phrases, you are getting the patient to open up more to you without you sounding judgmental. So these are some of the nice phrases that you can use. And I like this mnemonic because that helped me also build my own consultation style in palliative, managing palliative cases. So here are some more. Many times as INGs, we say, I'm sorry. I grew up with a lot of sorry. It's part of my culture growing up. Many people would understand what I mean by that. I grew up with, I'm sorry. But another way you can say is that I wish things were different. You see, so it's the words you use is the tone of voice. So if I say, I wish things were different, the tone of voice changes everything. I wish things were different, and I'm sorry that you've had to go through this. And then I move on to my next conversation. So I know that this conversation, I know this is a difficult conversation to have. I wonder if you've talked to the palliative team about a document called Do Not Resuscitate. You see? So I don't just shock the patient with having a conversation and then their anxiety goes through the roof. So some questions that you can also use to explore patient preferences, because your clinical management needs to achieve that goal that you are seeing the patient as an individual is. Questions like, what are your hopes for the future? Or what are your fears regarding your diagnosis? So that's another way to ask the patient's concern. What concerns you the most about your illness? What concerns you the most about your treatment? See, how is your treatment going for you and your family? Because we acknowledge that a diagnosis like this has an impact on the entire family. Can you tell me what's important to you at this point in time? So the patient then tells you their preference of care. So here are some phrases that we hope can help. It's not, don't just copy and paste it, use it in the right context, practice them, because you are building your own consultation style. And when it comes to the clinical management, it's nice to tell the patient what you can do, but we advise that you use action words. So you might say, there's a lot of things that we need to be putting in place for you. I would like to focus on what we can do at this point in time. It includes A, B, and C. And also you talk about the patient's own agenda first, and then you go on to say, I will like to do this. If you are happy with this, I would like to put this in place for you. Use your action statement to show that you are taking ownership of that case. Because if we are making sentences and it sounds like we are just pushing or brushing the patient off to the district nurse or the palliative team, that would impact on our IPS and our global task. So here are some nice phrases that we want you to look at and then try. Phrases to avoid in difficult conversations, especially around palliative care. Never use the word, we are withdrawing care. Because if you look at the new model of palliative care, we provide care even beyond death. Care might change, care might adapt, but we never withdraw care from patients and relatives. So if we use the word that we are going to withdraw care, we are going to stop the machine and pull the plug, we are killing our IPS for this exam and even in clinical practice. Words like, what do you want us to do at this time? You are dumping responsibility on the patient and you're not taking ownership of what needs to be done. So we've talked about phrases that you can use, but these ones may also seem it may also seem like you've not really practiced on your communication style, your words and phrases. So generally, party lads advocates that we should not be using phrases like this when discussing with patient. Don't say things like, there's nothing more we can do. If a patient has been discharged from palliative care, they've been discharged to our care as GPs, there are loads more that we can do. And the last one is, what do you want us? Do you want us to do everything? Now, this shows poor IPS, and you might take away the patient's autonomy because now you are going to start doing everything without empowering the patient. Now, there might be a situation where the patient is very distressed and anxious, and whatever you want to tell them will just fly over their head because they're stressed. They're not, once the patients hear the cancer word, their mind blanks out. So name what you see. I see that this has stressed you right now, but there are a number of things that we can do. I would like to do this. Would you be happy for me to see you in 2-3 days' time so that we can talk about what we need to do next for you? So you still have to give the patient that autonomy, but you manage that anxiety and stressful situation that the patient is in by offering to bring them in a later time rather than saying, oh, you are very stressed, so I'm going to do everything for you. That's not a good thing to do or a good phrase to use when having difficult conversations with patients. And of course, if your IPS is very bad and your tone of voice is not great at that time, it sounds like you are saying, do you want us to do everything for you? You can see with my tone of voice, the whole thing has changed. So we need to be mindful of our tone of voice, the phrases, and the choice of words we use in this in the exams or in clinical practice. So coming to the clinical management in palliative care, we break down, in every case you see, I always break down my clinical management. When I prime my case and write it down, I break down patient agenda first, doctor's agenda. So whatever the patient comes in, their concerns, their questions, address that first before you go on to address whatever you have found in your own data gathering. So in your data gathering, if you ask for anticipatory meds and you find that this patient is needing more or having breakthrough pain, you may choose that, oh, this patient needs a new dose of breakthrough medication, but that's not what the patient came in for. That's your agenda. So you address the patient issues first, then anything else you identify that needs to be done, those are the kind of things you then put in your doctor's agenda. And of course, your clinical management, I explained earlier on, depends on who you're speaking to and the phase of the patient's journey. So is it a new diagnosis? How you manage that will be different from if this patient is in a curative, having active treatment, or if this patient is palliative but not end of life, compared to if it's end of life or it's a patient who is end of life coming here to ask for euthanasia, because that's a current debate now in the UK, even up to Parliament. These are the things we need to be thinking about. Is it bereavement services or bereavement support that the patient relative is asking for, or are you speaking to a healthcare professional? Your clinical management needs to have a holistic approach. We've talked about this before, the biopsychosocial model. And your global task as a GP, you need to be showing that you are taking ownership. You are getting other people who need to be involved. And remember that family members also need to be involved. I've had to go in a care home. Many people have this experience. Care home, we saw the patient. I asked they were calling me for a visit, and I asked the manager, are the family around? Can you give them a call and let them know that their relative has declined and I'm coming out for a visit? That way, if they want to come out and see me, or we can have that conversation when I see the patient, we have it once. It turns out that the relative couldn't come. So I then said, oh, don't worry, I'll come for a home visit and I'll give the relative a call to update them. So always remember that family members, how do you involve the family members in the patient care? Very important in your holistic management. Now, we also need to demonstrate competency in managing complexities and handling difficult conversations. We talked about this before, documents, death and dying. What kind of difficult questions can the patient ask? If you look in the ICKS, there is a question where the patient asked, and there is a segment where it talks about how to handle conversations around prognosis. It's expected for us as GPs to be able to estimate, gentle estimation of patients' prognosis. Don't give false assurances, don't give false hope. We estimate it based on our knowledge of the pathology of the disease. But even though you are presenting or you're answering that question, you still need to offer hope at the end to say, though the situation is dire, there are some other things that we can be doing to make sure that you're comfortable. So how do you manage those difficult conversations with patients? Now, if you're speaking to a healthcare professional, you've got to show value for their own clinical opinion. And healthcare professionals can be PAs, can be nurse practitioners, can be paramedic. You can have a conversation with a district nurse, and how you speak to the district nurse will differ from how you speak to the relative. The district nurse may come and say, oh, I've seen Mr. Smith. He's got dementia, he's got aspiration pneumonia. I took his vital signs, and I think Mr. Smith is approaching end of life. That's a clinical opinion. You've got to appreciate that. Now, that's different from saying, thank you for telling me Mr. Smith has end of life. That's very different. The appreciation. So if you are thanking patients for giving you information, that's not really great because they want to talk to you. You should not be doing that. What I mean is thanking them and showing appreciation for their clinical expertise, because this is how you relate to fellow healthcare professionals. Their opinion matters, and you need to show that professionalism towards healthcare professionals. And of course, demonstrate the importance of information sharing, whoever you're speaking to. So if you're speaking to a relative, you've got to say, oh, we want to get the district nurse involved because they'll come out and see Mr. Smith and help you with medication. So you show that appreciation and that you know the importance of information sharing. We've talked about taking ownership of the case, because as GPs or aspiring, as GPs, I'll just say that as GPs and aspiring GPs, we are meant to be care coordinators or advocates for the patient. If you look in your portfolio, there is actually a competency point there that says takes ownership, coordinates care, understands the importance of information sharing. These are capabilities that we need to be showing as well. Now, when I learned this part, practice management as part of holistic care, it surprised me because I never thought about saying this. So if there's a new diagnosis and a patient comes to have this conversation and you're doing your cancer care review, you've got to let the patient know that we're going to put you in our cancer register, our palliative register, for you to have your annual reviews every 6 months. If this patient is end of life or there is a safeguarding issue, you may want to go and speak to a colleague about this. But you have to show ownership, not just deferring everything to another colleague, but these are some of the things you need to be thinking about. It's not a one-size-fits-all. We've presented every possible situation so that when you see that case, think about all these points in your clinical management and decide, is it relevant to that situation or to that case that you are taking care of at that point in time? So that brings us to the end of the managing the cases when you see them. Going forward, action plans. I would advise what you need to do this week. Look at your palliative cases and start working on your communication skills. There are some phrases there that you can use, practice with your group. Take a look at the GSF framework on the identifiers for patients so that you are able to identify the common things. If you get a heart failure case, what are the common identifiers for a patient in heart failure so that you are initiating those documents on time? Revise and understand the concept of patient's journey in cancer care, because that's very important in how you manage any cancer patient. And remember that you need holistic care, an organized approach in managing palliative care. So organized when you are doing your biopsychosocial. For example, if a patient comes to me and says, oh, doctor, I've got lung cancer and I'm becoming breathless. My organized approach will be to ask all my biological symptoms around the breathlessness, the cancer, red flags, differentials, before I move into psychosocial. So mood and then social. I won't ask, if a patient comes and says, oh, I've got breathlessness, I won't jump into palliative documents and then come back into breathlessness. That's not organized. So you need an organized structure in your consultation. If my patient comes and says, oh, I've got a diagnosis and I'm stressed and I'm anxious and my mood, I would focus on that first, then ask about symptoms of the cancer, so the biological and then the social. So you choose which one you do, but whatever the patient comes in with, start your data gathering with that and then move to the other two. That's an organized approach. And you should also have holistic care as well. When we talked about the SCA game plan, I talked about video resources that you can use. Have a look at them. There are some lovely cases there from the Transpennine Deanery about palliative cases, different ones there, listen to the video simulations on palliative care. Now, it's not listed that as this is palliative care. Go in and say, oh, this is a dementia case. I'm going to watch this because it could be a palliative case. Looking for prostate cancer, breast cancer, anything that could be palliative, use the resources around you. We've talked about learning to break down your clinical management, talk about patient-centered first, patient agenda first before yours, very, very important. We've talked about phrases to elicit patient goals, because that's important. And then good clinical care must be safe and effective for the patient. So these are the things that I would advise your action plan going forward to help you improve on managing your palliative cases. So to summarize quickly, we've talked about palliative cases. We've had an exercise to show why it's high yield. I think it's high yield anywhere because we see it in clinical practice. We have it almost on a daily basis. In our practice, there is meetings, patients come in and the conversations are complex, it's difficult. And in case of palliative, a palliative case is a good example for a doctor to show organized data gathering, communication skills, managing complexity. You can see that it ticks many of the boxes in the SCA blueprint. It's important that we understand a holistic approach in managing palliative cases because we need to demonstrate our ability to see beyond the patient's illness. So everything that goes on, their relatives, the documents, their finances, we've got to take that into consideration. When you, the doctor, needs to be an advocate for the patient, you're expert in coordinating patient care, you need to be showing that in your role play and your clinical practice. To demonstrate good communication skill when handling difficult emotions and conversations and be able to explain complex emotions around death and dying to the patients, that's a good way to show your communication skills. That's why palliative case is a very important concept to learn as you're preparing for your SCA. And of course, the IPS, because without a good IPS in palliative case, we would lose a lot. You have to be a responsive communicator, be able to say, oh, I understand that things are challenging, but offer hope, offer care, hope in the care that you're going to give to the patient. Show that verbal empathy, and we've talked about phrases to avoid. We've also talked about why good IPS and building rapport is important because that helps in your data gathering. It's not just about knowing the question to ask, but your question needs to be targeted, focused for the phase of the patient's journey the patient is in. And of course, demonstrate all that understanding, that rainbow colors around palliative care to make sure that you are having very high points in your exams. So if anybody doesn't know, this is the link, just some addendum. This is the link of the palliative medicine. I believe all of us should know this by now. Have a look in. And then sometimes you may see in clinic, we have cases of diabetes. This is one of the things I struggle with myself, so I always have this link handy. How do I manage that insulin and diabetes care when I have a patient? Or sometimes it's even epilepsy. So, for example, this is what the book shows, how to manage diabetes in palliative care, how to change medication. And with the cancer care review, when you go into your practice tomorrow or Monday, look into your addends, bring up cancer care review and look at the questions, look at the templates. This link can guide you. There's a nice YouTube video to explain the entire concept around communication or having a conversation with patient who is on the palliative care register. Very good link. And that brings us to the end of our session. So just to let you know that we have more tutorials like this coming up where we are discussing the difficult themes and difficult concepts that come up in the exam, like dealing with angry patient or domestic abuse. In one tutorial, we'll talk about the different presentations or the different ways you can see the clinical practice and how to manage each of them. So please subscribe and join us for these tutorials. Thank you, everybody. Any questions?